going to introduce Bonnie Chien to be the moderator for the next session. And I also want to thank our sponsor for the session, Osseo. We appreciate your support. Bonnie, it's all yours.
Great. Thank you, Selene. So it's my great pleasure to introduce first our topic and then our panelists for the topic. Of course, understandably, a lot of this session is on surgical management of ankle arthritis, but also just as important in taking a broader view is how to optimize patients for surgery, or sometimes some of these patients may not be medically ready or suitable for an extensive surgery to address their ankle arthritis. So what are some of the things we can do both preoperatively but also non-operatively to manage symptomatic ankle arthritis? So the topic of this particular session is going to be focused more on not just pain relief of ankle arthritis and operative treatment of ankle arthritis, but some of the other considerations that may improve symptoms for these patients, whether it's through weight loss, smoking cessation, and medications. And as many of us know, the advent and the growing popularity of GLP-1 receptor agonists in both addressing weight loss, sort of off-label, but also other comorbidities such as diabetes. So for our first session and panelist for today is Dr. Anis Dizdarevic. I hope I said that right. And he is my esteemed colleague in anesthesiology. He is an associate professor of anesthesiology at our shared institution at Columbia in New York City. He is the director of our regional and orthopedic anesthesia. And I thought it was a great idea and perspective to have somebody from anesthesia who can really speak, I think, a lot more about the medical part, especially the GLP agonist part of optimizing patients. Anis did his medical school at Harvard. He did his fellowship training at Brigham and Women's Hospital in pain management, which is an affiliate hospital of Harvard. A lot of his clinical interests are around perioperative management of high-risk patients, particularly for orthopedic surgery, as well as management of acute and chronic pain after surgery. So thank you so much for, I know it's a little bit atypical to come on a talk, and not just for orthopedics, but even more specifically on foot and ankle. So I really appreciate your time and your expertise for this session.
Thank you, Bonnie. Thank you so much. Thanks for inviting me, and thanks to everybody for having me. I mean, this is a really great opportunity. I mean, there's so much to talk about, so much to cover, so little time in ankle surgery, orthopedic surgery. But let's talk specifically about the topic that you mentioned, GLP-1 agonist. So GLP-1 receptor agonist and peri-op consideration. We'll talk about this particular topic, and it's been very important kind of topic, and there's a lot of still unknowns, knowns and unknowns to consider, and something that's going to be ever expanding in the time to come. We'll go over the agonist in particular, the mechanism of action, what these medications are really for, what are the some peri-op risks and consideration, what are the really anesthesiology recommendations, how to proceed and how to manage these patient situations. I mean, we all are seeing advertisements, commercials. I mean, you heard about some of these GLP drugs. Probably the most popular one that we know about are Ozempic and lately Mounjaro. It's been like a lot of press, and it's kind of ongoing, really a lot of press. It's kind of really taking up the whole industry by the storm. It's just kind of like a brief kind of a representation of how the market is really and demand and utilization has been moving. There's probably a dozen of these agents available on the market for a variety of indications. The main ones would be a treatment of diabetes, and also a few of these agents are approved for the weight loss as well. But back in 2014, one of the first generation short-acting agents was approved. But you didn't really see a much of a pickup, major pickup, really in use um, in the beginning, and then Ozempic was approved for diabetes back in 2017. Again, there wasn't really much of a popularity, much of an increase. Obviously, 2019 and 2020 kicks in, end of 2019, 20 with COVID and everything else that's been happening. But then there's like a probably mid to late of 221 and then 222, we really see the utilization of popularity of Ozempic really started to pick up. And then Mounjaro is another combination drug agent. We'll talk a little bit about that as well a little bit later. Gets approved, and it's been basically now almost kind of in a trajectory to take over as the likely most effective and most popular agent. But this is basically a list of some of these medications. Like I mentioned earlier, there's the first generation of primarily like daily use of the GLP-1 receptor agonist, and then the more popular one, Wegovy and Ozempic, most popular one. The medication they're used typically subcutaneously once a week. And then the combination drug that basically employs two different types of a basically like a hormone or peptide agonist like Mounjaro is becoming more and more popular. Study seems to indicate and show that these combination drugs actually even have a better overall effect in terms of weight loss and diabetes management or hyperglycemic control management. So as I mentioned, FDA approval has been given for these medications for the treatment of diabetes primarily, but also some of these medications have been approved for cardiovascular risk reduction, and then a few of them, I think 3 of them now, are FDA approved for weight loss. And several big associations, American Diabetes Association, American Association of Clinical Endocrinology, actually recommends early treatment initiation of these agents, especially in patients with higher cardiovascular and renal risk factors, right? So what are these agents really? I mean, they really mimic naturally occurring peptide hormone, GLP-1, glucagon-like peptide. One hormone is a hormone that's synthesized, basically released in response to a ingestion of food, and there's like several mechanisms that basically gets triggered in the body. The most important ones are stimulation of insulin release, which then regulates these glycemic spikes after eating food, and then also throughout, depending on duration of action. There's also suppression of the excess glucagon secretion. There's stimulation of the certain centers in hypothalamus and the centers that regulate hunger. And there's also a action on the stomach gastric neuronal cells, which then triggers delayed gastric emptying and induce basically a decreases the appetite and works as well to decrease the hyperglycemia. So, I mean, there's really several of these very, very good beneficial effects, and obviously that's why they've been so popular. I mean, it's been like a huge increase in utilization and popularity of these medications. But there's some potential side effects or harmful effects that also have been described and that we're paying attention to. And then we also already mentioned previously that these agents do trigger delayed gastric emptying, right? And as such, this results in prolonged gastric food retention and also gastroparesis symptoms. Actually, FDA has received reports of stomach paralysis, severe gastroparesis, and they switched the warnings and for some of these medications, just to basically make sure that patients and the providers understand some of these side effects and risks associated with the agents. So, as such, what's pertinent to our field, my field, and our field together is the increased risk of aspiration. during sedation procedure and anesthesia procedure. So this hasn't really picked up till probably sometime in 2023, and the anesthesia journals started basically publishing case reports, and other editorials point to the increased risk of aspiration during surgical procedures involving anesthesia with patients taking these medications. Interestingly enough, these are case reports, or maybe like, here and there case series, not really a huge number, but enough to basically get people thinking about, how do we really regulate these medications in the perioperative setting, and how do we really describe the risks of these medications for patients scheduling and having surgery, and how do we proceed. So the American Society of Anesthesiologists issued a consensus-based guidance statement in June, I believe, of 2023. That's right, June, July, on pre-op management of patients presenting for surgery. They're taking GLP-1 receptor agonist. So, in a nutshell, what they really focused on, how do we manage these patients? What do we tell these patients? How do we instruct these patients, and what do we do? So remember, there's like a short acting, there's a long acting, once daily or twice daily dosing versus like, once weekly sub-Q injection of these medications. So what they recommended in that guidance report is that for those patients scheduled to have surgery and they're taking GLP-1 agonist on a daily basis, they should be instructed to stop these medications the day before. For those patients, they're taking these medications on a once a weekly basis. They're instructed to stop the medication 1 week prior. For those patients, there's probably a lot of those patients on a weekly, especially weekly dosing regimen. It's also recommended that these patients consult with their primary care providers or endocrinologist or diabetes specialist on how to bridge that gap once they stop the therapy prior to surgery, so they don't experience hyperglycemic spikes and levels prior to surgery, because a lot of these patients do rely on this effective therapy. And then furthermore, they describe also how do we manage the day of the morning of surgery if these patients do present and the morning of surgery, but do complain of specific GI symptoms such as nausea, bloating, maybe even like some episodes of vomiting, that we should really consider canceling the case, meaning that most likely they still have retained gastric content and food in the stomach. If these patients do present after they've been instructed to stop these medications and that they don't have any GI symptoms, then we should proceed with a procedure as planned. And then the like in between is if they don't have GI symptoms, but they didn't really stop the medication as instructed, what do we do? Well, we can kind of consider perhaps scanning their bellies, and then based on that proceed accordingly. So our institution, it's a New York Presbyterian, Columbia campus, Cornell campus, a few other campuses in the New York City area, actually issued a policy, a recommendation for our own management of patients presenting for surgery or procedures, and if they're taking GLP-1 agonist, how do we proceed? So it's basically mirrored or based on the ASA, American Society of Anesthesiology recommendation. But in addition, there's a few other recommendations, such as patients could be instructed to, in terms of their NPO planning, go NPO for solid food the noon time of the day prior to procedure, and then NPO for liquids at the midnight or 8 hours or so the day before procedure. And in addition, that these patients should be really considered for aspiration precautions, which means if everything actually checks off well, no GI symptoms, everything is stopped appropriately, then those aspiration precautions are probably minimal. But in any other scenario, that anesthetic plans such as deep sedation, using the laryngeal mask airway, LMA airway, as you know, those are the airway devices that don't basically provide any safety against aspiration because there is no cuff involved. And monitor anesthesia care. All of these techniques should be avoided, and then we should really employ general anesthesia, utilize the endotracheal intubation and tracheal tube, perhaps like a rapid sequence induction to minimize the risk of aspiration. And we should really consider regional anesthesia with a combination of light sedation, right? Then there's also a few other recommendations, few other papers and authors really look into these issues. They're providing further recommendations. And why is this the case? Because we really don't know. And there are really some unknowns here. We're still kind of in the process of trying to gather more data and find out what really is happening. So some of the other authors have basically recommended that we should suggest the patients stop these medications essentially 3 half-lives before the procedure. 3 half-lives. So depending really which medication they take, that translates into if it's a daily dosing of these agents, they should really stop it 3 days before. If it's weekly, they should stop it 2-3 weeks before, right? To really minimize the risk of retained gastric contents. And why is this the case? Because studies have been emerging and showing that even when these patients do stop these medications as instructed, the previous slides, right? If we either have them have endoscopy procedures, so there's direct visualization, or if these patients do get gastric ultrasounds, probably in 40-50% of the time, some of these patients can still have retained gastric contents. There's another theory is that in the first 8 to 12 plus weeks of the treatment, there's a higher incidence of the gastric emptying, slowing gastric emptying and retained gastric contents. But then over time, there's a development of tachyphylaxis. So the gastric emptying kind of the slowing down of gastric emptying is not really the case much anymore. So if the patients have been taking these agents for a longer period of time, that probably their risk is less, but it's really unknown. And then, so if you imagine if you have patients that are taking these medications on a once a weekly basis for management of diabetes, and if you ask them to stop like 3 half lives before surgery, that would really translate it stopping them 2-3 plus weeks before surgery. So what are they going to do in the meantime? How are they going to really manage their diabetes, glucose in the meantime? So it's not really practical. Some of these recommendations, and then some of these other authors and studies are really looking into whether asking the patients to prolong their fasting, so be NPO for longer than 8 hours, might actually not be worthwhile because of a few reasons. One is prolonged fasting is not really beneficial overall in the peri-op setting, right? I mean, you're all aware of hyper kind of caloric liquid loading, especially in ERAS protocol patients, right? And also, it doesn't seem like they're really good. That goes along with the evidence, because we have seen in our own practice patients that stopped taking once a week dosing of these agents appropriately 7+, 8+ days before surgery, and do present with still increased amount of gastric contents. So it's really unclear whether we should ask them to prolong fasting or not, whether we should ask him to stop, a few of these half-lives before, because it really kind of becomes problematic what to do. We can't really predict which one of these patients will have more retained or less retained gastric contents, but so there's like a lot of unknowns. So at this point, we kind of really kind of taking this with caution. I remember like probably 7 months ago, we had a lot of patients presenting in for surgery, and there was a lot of confusion because there was no clear guidance about the instructions, what to do and how to manage these patients. Probably this was kind of like across the board. There was let me just stop this. There was probably some unnecessary case cancellations, but we kind of since then we kind of settled. What's also important to make sure that patients do understand is that a lot of times we will have situations where patients would not report using these agents when they were seen in the surgery office planning for surgery. And then typically the day before surgery, somebody from the pre-op nursing team would call them just to kind of run the list of all the instructions, everything, recommendations. And oh, by the way, yes, I'm taking Ozempic. When did you start taking Ozempic? I started taking it a few weeks ago. I didn't really tell anybody. When was the last time you took it? Oh, I just took it yesterday. And we will be getting all these phone calls from the nurses and from the surgeons and from the other members of peri-op team. Like, what do we do now? I mean, should we cancel? Should we not cancel? Patients come in, they present for like, let's say, a total knee replacement surgery, and what should we do? I mean, we typically employ regional anesthesia with neuroaxial spinal anesthesia block and some level of deep sedation. But now, if these patients come in, they essentially have full stomach. Should we really risk? Should we kind of treat them as full stomach? But then that's like really more for like urgent or emergent cases. So there was a lot of kind of confusion what really to do. We really seem to have settled to instruct the patients to stop these medications, as was already pointed out in a few of my slides earlier, and then do assessment of their symptoms the day before and the morning off. So if they're asymptomatic and they stop accordingly, we should proceed, but still thinking that there probably might be some increased risk of them having some gastric content. So as such, if we really have to kind of choose, we'll probably choose a safer way of anesthetic mode, which would be endotracheal tube, general anesthesia, as opposed to LMA and deep sedation. Or just use like a heavy regional anesthesia, surgical anesthesia block with some kind of safer mode of sedation. But remains to be seen how this is going to pan out, because there's a lot of these more agents coming on the market and they're going nowhere. I mean, this technology is just insane, and it's so popular, it's so beneficial, it's so good that we're going to be seeing a lot more of these agents available.
Great, thank you.
Any questions on the surgical colleague side?
I don't see any questions on the chat so far. But yeah, I think that was a great overview and definitely complicated, probably still controversial topic. And we don't really know the long-term consequences of a lot of these medications, but I really appreciate the nuanced take on it's not if you took the medication necessarily that like the case has to be canceled, but you take into consideration the degree of symptoms a patient has, to some extent, even the indication for taking a GLP agonist, whether it's for some underlying legitimate condition like diabetes, or whether it's more peripherally for weight loss. And as I was just wondering if there were any other circumstances where you felt that maybe it's a little bit more black or white, that definitely we should cancel the case, or maybe we can accommodate it for something more urgent.
Yeah.
Just from your experience.
I mean, so all of these really guidelines or recommendations do stress out that it should be explained to the patients that if you're taking these medications, hey, these are the potential risks that go along in a peri-op setting, and as such, it should be discussed with the patient that we're going to take our obviously precautions and measures, but just so you know, you're likely at higher risk of potentially aspirating. And this has resulted, regardless of really our recommendations, to some of the patients just not willing to proceed with elective surgery just because of the fear of like, what if something goes wrong? And I really don't want to be thinking about it right now, especially something kind of like a little bigger, kind of a little more involved, something that kind of requires a little more planning. But in terms of the black and white, that's, I mean, it's kind of really hard to tell. I think we've definitely have gone into like a more kind of a cautious, but not necessarily like immediately cancel type of a mode nowadays, where patients do present, they're taking it, but they're like fairly asymptomatic. We do explain the risks, we do discuss some of these things, and then we kind of take the a more kind of or safer approach. So we really, you know, going that route, and we haven't really been seeing an uptick in these aspiration incidents. If you think about it, I mean, there's a lot of patient across the board utilizing these drugs, and there's only case reports of these aspiration. Now, obviously, aspiration is a pretty kind of a I would say high risk issues in the peri-op setting, and obviously we don't want to like really experience uh, those situations, but we're not really seeing a lot of these cases. So it's not maybe as significant or serious that it might seem to be, but we still kind of have to take precautions. So as we're studying more and more and kind of maybe look into the duration of these therapies and maybe some kind of like a different other risks factors among the patients, we kind of get more data. Now, uh, some of these papers actually looking into gastric gastroparesis, retained gastric contents, slowing down of the gastric function, gastric ultrasounds, are really pointing out that it's not just the medication that sometimes causes these issues, right? I mean, patients do have diabetes, a lot of times do have autonomic dysregulation resulting in decreasing gastric transit time and you know, increased gastric contents and possibly retention. So we do probably, I mean, as you know, I mean, we do surgery on patients with poorly controlled diabetes on a weekly basis, and we don't necessarily take as these extreme precautions with these patients. So there's a lot of unknowns as of now, but we'll kind of keep studying them and kind of looking to see what the future holds.
Great. Thank you so much. All right. So then we'll proceed to our next speaker, Dr. Turner Vosseller. So Dr. Vosseller completed his medical school and orthopedic residency at Georgetown, and he did his fellowship in foot and ankle at the Hospital for Special Surgery in New York. He was at Columbia University, affiliated with the New York Presbyterian Hospital System for 9 years. And then I came in to try to fill in the big shoes. And he's now returned to Jacksonville, Florida, where he is in private practice and is the consultant for NFL Jacksonville Jaguars. Dr. Vosseller is really involved in a lot of international foot and ankle, both mission, surgical trips, and he is serving as a member at large, very prestigious position as part of the AOFS board of directors. So honored to have you on board.
Thanks so much, Bonnie.
Of course.
All right, so today I get to talk about medications and injections, which are things we don't necessarily get to talk about always as surgeons. So we'll kind of go through some of this stuff and try to figure out whether this is genius or alchemy or snake oil or maybe a little bit of all that. My disclosures aren't really relevant here. So in putting together this talk, I wanted to try to figure out the best way to do it. So I thought, well, I wanted to use a lot of colors apparently, but I wanted to talk about, what actually we're talking about, and then why the given thing that we're talking about may be beneficial. And then finally, and perhaps most importantly, what is the evidence? And going through all these colors, I saw this kind of red and green. And so I thought it might be good to put the things in green that have a lot of evidence and the things perhaps in red that have less evidence. So here we go. So we'll start with topical NSAIDs. In the US, there's a topical diclofenac or Voltaren, which is over the counter. Patients use it quite a bit, as you'll see quite a few times. And the idea here is we're just simply trying to mitigate inflammation. But in putting together this talk, it's interesting when you look in perhaps the non-orthopedic literature and see how the degree to which some of these things have been studied. And there's actually quite good evidence for the efficacy of topical NSAIDs, specifically for osteoarthritis, with superior to placebo for osteoarthritis-related pain and also significantly improved physical function. So we put that in green since there's pretty good evidence for it. It's also quite interesting to read about capsaicin. So certainly it's something we've known about for a long time. It's the active ingredient in peppers. It's really what makes them spicy. And historically, like back when I was in med school and perhaps even more recently, we thought it worked to deplete substance P, which is kind of a nociceptor neurotransmitter. And I put the Nobel Prize thing down there because actually the Nobel Prize in Physiology and Medicine was won in 2021 for better working out basically the mechanism of action of capsaicin. And how it works is by the defunctionalization of nociceptive fibers. Essentially, it makes it so that they don't work as well. And so pain isn't transmitted as it normally would be. Once again, I mean, there's good evidence that capsaicin is superior to placebo for pain relief in osteoarthritis pain. There's also, Qutenza, which is simply a capsaicin patch, which has been used in neuropathic pain with some success, although I don't think that's been used for pain associated with arthritis as of yet, but pretty good evidence to support it. Oral NSAIDs, I mean, obviously these are pretty ubiquitous. You don't really have to be in medicine to kind of know at some level that these can be beneficial for osteoarthritis pain. And, we could probably spend more time than we would want to going through all the studies for the different NSAID medications. And so I just kept it pretty blanket here since there's a lot of efficacy there. Generally speaking, in my practice, I have 2 or 3 NSAIDs that I use regularly. I have people use over the counter, but then also prescription, because it tends to be individualized in my experience. And the COX-2 inhibitors may mitigate the adverse events that can certainly come with prolonged use of NSAIDs. So if we move on to injections, so another interesting thing to note, corticosteroid injections, obviously pretty ubiquitous in orthopedic practice, used for a host of indications, certainly arthritis being one of those. And as we said, trying to mitigate joint inflammation here. Specifically in the ankle, there's a surprising, almost shocking lack of evidence because there's really only 4 case series, almost unbelievably, that have looked at specifically corticosteroid injection into the ankle joint for ankle osteoarthritis. And one of those was published in the 70s, and one of those was really more of a radiology study just to prove that they were getting in the joint. And so the evidence is largely extrapolated from other joints. And just put up this is the most kind of recent systematic review and meta-analysis, which I think this was published in February of 2024 in KSSTA. And the conclusion basically was that you get short-term pain relief and functional improvement that loses its relevance after 6 weeks, which is pretty damning kind of negative view of corticosteroid injection. That data is what it is, certainly. Certainly in my practice, I'm sure is true for many of the people that are listening now. We certainly have, or I have those arthritis patients who come in every 6 months or 8 months and get their injection and they're good for a while. I certainly have patients in whom it's not quite that efficacious, but it's certainly a very reasonable thing to do, low risk. And so we put that in orange, so it's somewhere in the middle there, since there is, like I said, a pretty surprising lack of evidence. So hyaluronic acid is an interesting adjunct here. So it's the primary kind of non-protein component of synovial fluid. And really has a lot of benefits. I mean, and those can be broken down into kind of mechanical benefits versus pharmacologic benefits. And the mechanical benefits largely relate to the fact that it increases the synovial fluid viscosity. And so that improves lubrication. It, kind of restores and improves the shock absorption. And interestingly, these kind of large molecules just act as a barrier to the nociceptive fiber. So it really just kind of blocks the transmission of pain quite literally. The pharmacologic benefits, interestingly, when you inject hyaluronic acid, you increase the body's production of hyaluronic acid. It decreases cartilage cell apoptosis and generally decreases inflammatory cell activity, all of which obviously are positive in an arthritic model. So if we get to the clinical data, I mean, obviously at the end of the day, that's really what we care about. There's really 3 randomized controlled trials that have been used or that have been done surrounding hyaluronic acid, specifically for ankle osteoarthritis. None of these were all that recent. So this one was published in 2008, and then a subsequent one just a few years later in foot and ankle and in JBJS. These both used Hyalgan, which is a series of 5 injections. And both of these studies were pretty positive, noting increased pain function. They specifically looked at the ankle osteoarthritis score and WOMAC, as well as stiffness at 26 weeks. Actually, the more recent study looked at Supartz, which Supartz is just a single injection, and that noted no difference in VAS, ankle osteoarthritis score, or AOFAS at 12 weeks. And so a subsequent study published in 2018 by Mo Bandari and his group up in Canada basically put all these together and based just on these 3 RCTs, performed a meta-analysis looking specifically at the ankle osteoarthritis score, since they got that in all 3 of those studies. And they noted that there was no difference at 6 weeks and at 3 months, although the hyaluronic acid was superior to placebo at 6 months. So, in the United States, it really comes down to a practical question. So hyaluronic acid injection is approved by the US Food and Drug Administration, or FDA, for the knee. And so practically what that means is that insurance companies will pay for it for the knee. It is not approved for any other joint. And so, which once again, practically means that insurance companies will not pay for it for the ankle. So it ends up being an out-of-pocket expense for patients. And these injections run anywhere from maybe $250 or $300 to $1,000, and so they can be certainly quite expensive, and in some instances prohibitively expensive for patients. So practically, it's not done that often, and that's largely the reason why. Although there is reasonably good evidence to support it. So if we get to kind of the elephant in the room, which would be platelet-rich plasma, the regenerative clinic, if you will, has become a bit of a cottage industry, certainly in the United States. And some of the advertisements, which are many and liberal, can, as a surgeon, can be a bit frustrating when they categorize steroids and surgery as "quote unquote" old treatments. And all you have to do is do a quick search, and you'll see that regenerative medicine clinic, brings back 23 million results. So obviously, there's quite a bit of industry, or quite a bit of interest in this as a treatment, and certainly in regenerative medicine as a generalization. And just so we're all speaking the same language, when we say platelet-rich plasma, obviously we're talking about derived from whole blood, has a concentration of platelets above baseline. The platelets harbor these bioactive factors that potentially could mediate an anti-inflammatory, anabolic, analgesic response within an arthritic joint. If we look at the clinical data, so there's actually been a lot of fairly recent work. There were 2 meta-analyses that were published in 2023, one in International Orthopedics, one in Journal of Orthopedic Surgery and Research. And there weren't that many studies for them to look at, so they looked at a lot of the same things, and appropriately had similar conclusions, which is the following. Number one, that there was limited data. There's a lot of variables that go into PRP in terms of how it's derived, how it's formulated, and also what the individual's protocol is, whether it's a single injection, multiple injections, what they do afterwards, if they immobilize someone, don't immobilize someone, whether they can take anti-inflammatories or can't take anti-inflammatories. And so ultimately, the data becomes very heterogeneous with all those variables in there. And generally speaking, what they found is that uncontrolled studies generally showed a positive effect, whereas controlled studies, it was more difficult to demonstrate a positive effect. And so I think that's a fair generalization of the data. And then also recently in 2023, in October of 2023, this study out of the Netherlands was published specifically looking at platelet-rich plasma for the treatment of ankle osteoarthritis. So this was a 1-year follow-up of a study. They had actually published the 6-month results in JAMA, but this was published in AJSM. So this was a rarity, if you will, in orthopedics, and a very well done study. It was prospective, randomized, double-blinded, and included 100 patients, 1-year follow-up. Interestingly, they chose as their primary outcome this modified AOFAS score. So For a lot of us that are very involved with AOFAS, very few of us use the AOFAS score because it's not validated. Now, there's a surgeon component to it, and so it's not strictly a patient-reported outcome either. And so they basically took out that part and modified the score somewhat. And in their paper, they actually say that they've, demonstrated the test-retest reliability and so on and so forth of their version of the AOFAS, but they say that that data is unpublished. So that they've certainly been criticized for using that in this study. But they also have a host of secondary outcomes, as you can see here, including the foot and ankle outcome score, that same ankle osteoarthritis score, the AS is ankle activity scale, SF36 visual analog scale, GAS is a global attainment scale, and EuroQual 5D3L, which is a quality of life metric. And so, once again, very good study. 2 patients lost to follow-up, very, high follow-up numbers. And ultimately what it showed was that there was no difference in the primary outcome that they used, nor did any of the secondary outcomes show any benefit of platelet-rich plasma over saline. And so, once again, uncontrolled studies tend to show a benefit. Controlled and certainly well-done studies, the benefit tends to kind of evaporate, which may at some level speak to a rather strong placebo effect from platelet-rich plasma, given that situation. So in conclusion, obviously anti-inflammatory medications can mitigate the symptoms of ankle osteoarthritis, as we know. Injections, can be used judiciously and are certainly reasonable, relatively low-risk options that may at least be able to mitigate symptoms for a while. And ultimately, the data surrounding regenerative medicine is generally poor, although perhaps increasing. And the better evidence that exists suggests that it is no better than placebo. So certainly a lot of thanks to go all around. I have to thank all my people who are right here, little ones included. And then thanks to all of you, and certainly to Selene and Bonnie for including me.
Great. Thank you so much. Love the color coding.
Thanks.
Helps with organizing some pretty messy data out there. I don't see any questions in the chat so far, but I think it makes me think about how this might change my own practice, and hopefully for many of the participants as well, in that something as simple as a topical anesthetic, like you mentioned, Voltaren, has pretty decent evidence, and almost counterintuitively, or I don't want to say shockingly, but a little surprisingly, in contrast with steroid injections directly intra-articularly, because it just seems so commonplace, at least what we do on a regular basis, not just in the foot and ankle, but in the hip and the knee. So I think certainly that seems to be a great option of something easy, low-hanging fruit that you can offer the patients. We all know that giving cortisone injections frequently, there's diminishing returns. It, as you have demonstrated, doesn't always work, and there can be some risks of infection if they eventually undergo something like a total ankle replacement down the line.
Right.
So, and yes, totally agree. The hyaluronic acid part of it is sort of a bane of our existence because it's not covered by insurance, even though there does seem to be some evidence. And I think it mitigates some of the potentially detrimental effects of steroid injections, whether it's increasing risk of infection or even some of that kind of chalky calcific deposit that we see sometimes when patients have had multiple rounds of injections of steroid.
Right. Yeah, and just to speak to some of the questions there, I mean, Selene asked about lipid-based MSCs, and somebody else asked about bone marrow aspiration. I specifically didn't include those just because the data is kind of like PRP. I mean, there's just not a lot of it. Although it's certainly shown some benefit. There's not as many kind of randomized trials, so it's a little bit harder to make firm conclusions there.
Yeah, for sure. So thank you. So we have one last talk that's a pre-recorded session by Dr. Alistair Younger. He wasn't able to make it in person for the last 15 minutes or so. So Dr. Younger is actually based in Canada, and he did his medical school training in Aberdeen, Scotland. He did his residency in Vancouver at the University of British Columbia, fellowship at University of Washington in Seattle. He's a full professor now at the University of British Columbia in Vancouver. He is past president of the Canadian Orthopedic Foot and Ankle Society, has published extensively, not just on ankle arthritis topics, but many other foot and ankle related topics, and has garnered many awards, the Takakura as well as the Roger Mann Award for a lot of the work that he's done. So I'm going to share my screen so that I can play his pre-recorded presentation.
Hello, my name's Alistair Younger. I'm sorry I can't be with you. I have to host a dinner during this time. So I'm going to just go through my tips and tricks on ankle fusion, preparing the patient for surgery. While I must talk about smoking, I think that diabetes and obesity are a greater risk. Smoking is a definite risk, and we're going to go through that. Here's my conflicts. None of them are direct to this particular study. So I work in Canada, and we do have the luxury, at least in elective surgery, of having longer wait lists. And that means that we're actually can have time to work on patients' health before they get surgery. But regardless, I think that it's important that you do that. And so there's really two groups you got to think about with regard to smoking, diabetes, and obesity. And that is the elective surgical case where you have time to intervene and you have the opportunity to even refuse if the patient's not complying to your recommendations. Or in trauma surgery, well, there's no time to intervene. You don't necessarily get to choose your patients, and therefore you have minimal opportunity to refuse based on risk, but you can mitigate that risk, and I'm going to talk about that. The ultimate goal is you need to do what is good for the patient and prevent complications. And while I hear people say things like, well, they're going to go next door or whatever, or this is adequate surgery, or it wasn't my fault, your reputation is actually based on how you perform. So the principle is still do the best surgery for the patient and optimize it. In this book, 48 Rules of Power, Rule 5 is so much depends on your reputation, guard it with your life. And you need to earn the reputation of being the best. And you get that reputation by minimizing your complications. It's not so much that you earn a good reputation, you avoid earning a bad reputation. So your good reputation occurs because you avoid a bad reputation, and nothing gives you a bad reputation faster than wound complications in particular, and non-unions. And everyone has wound complications, and they are nasty. And so in ankle fusion, what can go wrong? Well, wound breakdown is really the catastrophic complication of foot and ankle surgery. It's what leads to amputations. Wound infection is actually secondary to wound breakdown, and non-unions occur in patients who either have diabetes or
Whoop, got cut off, it looks like. I'm going to advance it to this one.
separate the two of them. So if we study wound healing, here's some of my complications. These are ankle fusions or ORIFs, and over the years, I've gathered my own series of rather nasty wounds, and some of them present to me, and others are ones that I have created, like these and this. And these are all the various diabetic feet that I've had to look after over the years, or some of them. And it shows what happens with diabetes and how the skin breaks down, how the infection spreads, how it penetrates the bone. And these are unique complications of diabetes. Nobody else gets these complications, and it's a failure of the healing cascade. And it leads to deep infection, as shown here. So it's a challenge, skin and bone healing in Charcot diabetes surgery. The failure of the healing cascade results in non-unions, and it's hard to get good science on it, but there are papers showing that patients with diabetes are more likely to have a non-union after a tibia fracture. It's likely is secondary to increased sugar levels, impairing the proliferation of osteoblasts and fibroblasts, and growth factors are impaired, such as beta fibroblastic growth factor, TGF-beta, and PDGF. the orthopedic end results is that there's an increased rate of fracture. And it's not so much that the patients actually have a higher risk of fracture, it's just they don't form the new bone. So the osteoblasts are not working, the osteoclasts work, and the bone just disappears. And the end result is that you get destroyed bone, and you get non-unions, and you get Charcot fractures. So non-union effusions in the spine and in the ankle has been demonstrated to be higher. Bone healing in diabetes was noted to be impaired in 1972, and they have a longer rate of fracture healing. It was written up in this paper, which is really an excellent paper by McAllis, Hogan, and Dr. Dombrowski and colleagues. And they did a review of 24,000 Achilles repairs. So a nice volume of an isolated surgery. And those that had medical comorbidities had higher rates of infection, and diabetes and vascular complications resulted in the highest rates of skin infections. And the presence of a medical comorbidity increased the cost and duration of surgical site infections. So we can see that diabetes, that is tops the list, diabetes with circulatory involvement, neurological involvement, peripheral vascular disease. So we've just got the obesity and the smoking right here. These pathologies don't exist in isolation. Your patient may be obese, diabetic, and a smoker, and maybe even a drug abuser, and they still need your care. And so you can't really unwrap these complications. You got to think of them as being comorbidities, and important to think of them that way around and try and intervene to improve what you can. So we can see that fluid and electrolyte abnormalities, drug abuse, depression, anemia, obesity, congestive failure are all relevant. And if you can control their congestive failure, improve their anemia, address their fluid and electrolyte imbalance, get them to lose weight, get them to quit smoking, you're going to get into a much better situation than you were when you started. And this is going to take time. And it's worth sitting down and having a contract with patients so that they can do this. This is just a patient that of mine that I treated in long term. Just shows some of the things we can do when we take care. So this is a patient in 2005, and an ankle looked like this. He failed to control his diabetes, and he had a sinus in 2013 and an infection. And so these are his CT scans. You can see the abscess forming, the bone distraction, the SPECT CT, and the soft tissue views. So the first thing to do is to listen to the patient. And this patient said, I don't want a below knee amputation. So we have to optimize things. We obviously can't wait with this infection. So I washed him out. And nowadays I do this as an arthroscopic procedure. And I used antibiotic loaded pellets, a retrograde rod, fusion. I'd also put surrounding screws around this these days. And we were able to eradicate the infection. And we also looked after him afterwards. We worked on his sugar control, and we followed him closely. Because we did that, because his sugar control improved, his life expectancy improved, because the renal and cardiac complications are directly related to the A1C. So if we can get the patients on board to get their A1Cs under control and their weight down, then things will be successful. So how do we mitigate the risk? Well, we need a thorough consent, we need smaller incisions, and we need to optimize medical care through smoking cessation, weight loss, and diabetes control. And if you can address those things and also add vitamin D treatment, you're in good shape. So this is a patient of mine. She's 30 years having diabetes. She's got an insulin pump, an A1C of 5, and she has a painful varus malunion. So obviously tibia fracture, a bad area for skin healing, a bad area for bone healing. And if you just said the patient has diabetes, you'd say bad opportunity for correcting it. But because her A1Cs are low, we were able to do this osteotomy and correct her deformity and get successful skin and bone healing. So getting an A1C down from 8 to 6 or 5 will dramatically improve the ability of skin to heal and the ability of bone to heal. And in some cases, I've been able to get bones and skin to heal purely by improving sugar control or purely by getting the A1C under control. So you need to improve the sugar control first, and then operate when the A1C is lower. So if you've got an acute fracture where the HbA1c is over 7, you might consider strong fixation. You might consider minimally invasive techniques. you might prolong the time of weight bearing and consider bone stimulation. In general, going non-op doesn't actually mitigate the risk. So this is a wound healing issue, and this can be mitigated by percutaneous surgery. So this is a patient who's had diabetes for 20 years. She's 65 years old, and her HbA1c is 7.5. With this trimal fracture, we can't delay. And my own experience is that we don't do well with non-operative treatment in these cases. They slide over in the cast, they get pressure sores, and things are generally miserable. I like to fix these. I don't like to use hindfoot fusion nails. And this was what she looked like on the table. We reduced everything percutaneously and arthroscopically. We confirmed it. We used growth factors and a rod, and she ended up with good healing. If your patient with diabetes has an A1C under 6, you can do standard surgery. 6 to 8, then you use less invasive techniques, stronger hardware, and consider bone stimulation. And over 8, you might delay a little bit. Try and optimize them with the medical service. You don't want to delay much more than 2 weeks. I would not consider non-operative treatment. Over 8, cancel the patient for elective surgery, improve their sugar control, get weight loss, smoking cessation, start vitamin D, and consider surgery once it comes down under 8. And this is really a contract with the patient. You've got to explain to them that their risk of complications are such when they're overweight, when they have high A1Cs, and when they smoke. It's just not worth the risk. And we can change this. So ankle fusions, we can use arthroscopic techniques, we can use bone stimulation, we can use percutaneous fixation to mitigate the risk. You really don't want to be doing joint replacements until the A1C is under 6, and that will help you. So not all patients with diabetes are the same. HbA1c is the best measurement of severity. Measure and change your management accordingly. But I also think broader than this, just like if you're overweight and you're telling patients to lose weight, it's a bit like somebody sitting in front of you smoking, telling you to quit smoking. So when we think of this, we have to look at ourselves first, because the obesity epidemic is not just patients, it's hypothyroidism.
All right, just in the consideration of time, I'm going to stop Dr. Younger's presentation so that we have sufficient time to prepare for the next session. So thank you everybody so much for your attention. The recording will be available, including Dr. Younger's pre-recorded presentation.
Bonnie, Turner, Anise, thank you so much for talking about stuff that in a surgical meeting we don't spend a lot of time on. So I really appreciate it. Thanks, everybody.